It's an honor to be here and talk about the results of the DoReMiFa study. As you may know, this is a large observational study which was conducted in 6 countries. In 22 ICUs, 1,762 patients were observed with a question to evaluate the impact of fluid overload on clinical outcomes. And we were particularly interested in patients with and without acute kidney injury.
I got it.
The primary outcome was ICU and hospital mortality. 1,752 patients were observed. Of those, almost a third, 760, had acute kidney injury. And of those, almost a quarter needed renal replacement therapy. Now, the primary interest was fluid therapy, fluid overload, and the implications on outcome. So in the first instance, as you may know, this study showed that fluid overload was bad. And this is one of the slides where we essentially showed that fluid accumulation occurred before and after the development of acute kidney injury. This is the first day of acute kidney injury, and if you use this as a reference point, then you can see that fluid buildup in the preceding 3 to 4 days. And even after the development of acute kidney injury, fluid accumulation continued and more fluid buildup. So, consistent with a lot of other studies in the literature, we showed that fluid accumulation was common, and it occurred pre-AKI and post-AKI. We then proceeded to look at maximum fluid accumulation in different groups. And maximum fluid accumulation was determined by the weight gain from baseline. So the percentage in weight gain from baseline, which was thought to be due to fluid accumulation and fluid gain. And as you can see here, in patients with acute kidney injury had significantly higher degree of fluid accumulation, a higher degree of maximum fluid accumulation compared to patients without acute kidney injury. So during their stay in the intensive care unit, even patients without acute kidney injury accumulated some fluid, but the patients with acute kidney injury accumulated more. And when you looked at patients who subsequently needed renal replacement therapy, they accumulated even more. So on average, their body weight went up by 8%, but there was obviously some range, and some patients accumulated much more. So fluid accumulation is a serious problem, and it's particularly common in those who die. And as shown here in this graph, fluid accumulation is particularly common in patients who approach their final days of life. As seen here, in those who died, the average weight gain was 8.6%. And the fluid gain occurred in patients with and without acute kidney injury. And so we concluded from this observation that patients who approach death accumulate quite a lot of fluid. Now, fluid overload is common, as I've already said, and there is a hint that it's even more common in those who die, and that's why we subsequently then differentiated between survivors and non-survivors. And as you can see here, patients who died in green had a higher maximum fluid gain compared to patients without acute kidney injury, and compared to patients who survived. And this figure includes all patients with and without acute kidney injury. If you differentiate between the 3 different groups, then the trend persists. Patients who died tended to have a higher degree of fluid accumulation and tended to accumulate more fluid to the point of some of them being fluid overloaded. The degree of fluid overload was highest in those who subsequently needed renal replacement therapy, and it was highest in patients who died, here in green in this figure. In a multivariate analysis, we looked at the impact of fluid overload and tried to correct the impact for usual risk factors. And in a multivariate analysis, looking at the data of all patients, the accumulation of fluid turned out to be an independent risk factor for hospital mortality. So for a 1% increase in body weight, meaning a 1% increase in fluid accumulation, the risk of dying increased by 2.3%, taking into account that we had corrected for all the usual risk factors and severity of illness. Now, this multivariable analysis took into account all patients. So we then differentiated between patients with and without acute kidney injury. And if you look at patients without acute kidney injury, then the impact of fluid overload diminishes. And in fact, when correcting for all usual risk factors, fluid overload alone is no longer an independent risk factor. So in patients who don't develop acute kidney injury, the other risk factors for dying were more dominant and important. However, when we then looked at all patients with acute kidney injury, whether they had come in with acute kidney injury or developed acute kidney injury during their stay in the intensive care unit, accumulation of fluid was a very important risk factor, even when correcting for all the usual risk factors. And so in this group of patients, fluid gain resulting in a 1% increase in body weight was independently associated with a 2.1% increase in mortality. So these results clearly confirm what Professor Mehta already said and what Professor Pinsky was saying: fluid overload is harmful. With regards to timing of renal replacement therapy, it's important just to look at the cohort of patients who needed renal replacement therapy in more detail. If you again use the first day of renal replacement therapy as your reference group, here in the middle, you can see that patients, again, experienced fluid accumulation in the 3 to 4 days prior to needing renal replacement therapy. Following the initiation, fluid gain continued very briefly, but then obviously renal replacement therapy was able to remove excess fluid. And that's one of the reasons, one of the main indications for starting renal replacement therapy. But as you can clearly see here, the time to remove excess fluid is much longer than the time it had taken to accumulate fluid. So it's much harder to remove excess fluid once it has occurred, and it takes longer. And clearly, the more fluid overloaded patients were, the longer it subsequently took to get back to a neutral fluid balance again. And again, we looked at this cohort in more detail and looked at fluid accumulation at different time points. And this figure, I'll go through it in detail, shows that fluid accumulation continues to be a problem even when patients are on renal replacement therapy. So if you look at the different time points here at the bottom, this is the cohort of patients who needed renal replacement therapy. This is time point when the diagnosis of AKI was made, time point when renal replacement therapy was started. That's maximum fluid overload, that's a peak fluid accumulation, and that's the day of renal replacement therapy discontinuation. And at all times, patients were still fluid overloaded. On average, the average fluid balance was positive. And importantly, again, there was a difference between patients who survived in blue and patients who died in green. Even whilst on renal replacement therapy, so modality to remove fluid, the patients who subsequently died were shown to be more fluid overloaded. We briefly looked at the type of modality to remove fluid and looked at patients who had been started on intermittent versus continuous renal replacement therapy. And as you can see here, there was no major difference with regards to the speed of removing excess fluid. So from the DoReMiFa study, based on the data from 6 countries, from 22 ICUs, we can conclude that in this observational study, fluid overload is very common in patients with acute kidney injury. It's very common in patients who require renal replacement therapy. It's associated with an increased risk of dying. And fluid removal, despite using RRT, is not easy. It's difficult. It takes longer than for fluid to build up. And quite a lot of patients remain fluid overloaded whilst on RRT. So what does this mean for timing? When should we therefore start renal replacement therapy? Well, the DoReMiFa study didn't address this. We didn't look at that. This was an observational study. But it's worthwhile looking at the conclusions of ATKI 12 again. And ATKI 12 was a consensus meeting with a focus on fluid therapy. Therapy including initiation, discontinuation, and fluid removal. And the 2 working groups focused on fluid removal with particular attention to the indications for drugs, diuretics, pharmacological measures, and mechanical fluid removal, in particular either ultrafiltration or renal replacement therapy. And the consensus statements and conclusions were summarized in these 2 papers. But essentially, it was agreed by the whole group, by the whole ATKI conference, that fluid overload needed to be treated, ideally needed to be prevented, but if it occurred, it needed to be treated. And the goal of therapy should be to remove it safely without any significant adverse events, and to remove it timely. Timely meaning before the onset of any life-threatening complications and before the onset of any implications for future prognosis. And it was recognized that diuretics seem to be the first-line therapy in most cases, but renal replacement therapy clearly has a role, and it has a role when diuretics lose their role, when they're no longer indicated, when there is pharmacological failure. And clearly the threshold when to move from diuretics to renal replacement therapy is very variable in clinical practice. But it's important to remember and to appreciate that these drugs have side effects and also may fail, may not work. And so ATKI 12 defined pharmacological failure really to help determining the time point when to start renal replacement therapy. And pharmacological failure, or failure of diuretics, was defined as the failure to generate an adequate diuresis to achieve the target fluid balance, or the occurrence of important side effects, meaning the drugs are no longer safe.
When is the drug safe?
The indications for fluid removal by mechanical devices, i.e. either ultrafiltration or renal replacement therapy, are fairly clear. It's either established fluid overload in the context of failed diuretic therapy, or in the situation where diuretics are unlikely to fail, where there's no point in even trying them, as for instance, patients with advanced chronic kidney disease. Renal replacement therapy should also be considered when there is a high risk of fluid overload. Given the fact that fluid overload is so harmful and associated with a high risk of dying, there are situations where we can predict that fluid overload may occur simply because patients are in need of very high amounts of fluids, bloods, or whatever. And where we can also predict that diuretics are unlikely to be effective, for instance, as a result of hemodynamic compromise or very severely advanced chronic kidney disease. Again, in this situation, it may be wiser to move straight to renal replacement therapy as opposed to a failed trial with diuretics. And then finally, renal replacement therapy should be considered early when there are signs of side effects or adverse events from diuretics. And you could put these indications into an algorithm or as shown here. So when faced with somebody who is very fluid overload or at risk of fluid overload, there are 3 questions. Is the patient at risk of severe complications of fluid overload? Is diuretic resistance likely or already present? And also, is solute removal necessary in addition to fluid removal? And if the answer to all these 3 questions is no, then it may be acceptable to start some diuretics together with fluid restriction, with the understanding that the situation is dynamic and that patients may not respond or their overall clinical situation may change, and that a regular reassessment is required. And if anything changes, if the answer to the 3 questions is no longer no, then clearly this is an indication for renal replacement therapy at an early stage. So in conclusion, the DoReMiFa study clearly highlighted that fluid overload was common in ICU patients across 22 ICUs in 6 countries. So it's likely to be a problem worldwide. It's particularly common and problematic in patients with acute kidney injury, and in particular those who need renal replacement therapy. The DoReMiFa study showed that fluid overload was associated with an increased risk of mortality and even small amounts of fluid accumulation. So a 1% increase in weight gain was associated with a 2.1% increase in hospital mortality after correction for all the usual risk factors. When talking about timing, it's important to remember that fluid removal is not easy and can be tricky and can take time. And DoReMiFa clearly showed that patients on renal replacement therapy remained fluid overloaded. And it took quite a while before they had reached their target weight again. And finally, based on the ATKI conference, ATKI 12, renal replacement therapy or ultrafiltration should be considered early when there are clear signs of fluid accumulation and pharmacological failure. Thank you very much.